We also have a lot of free patient education material on healer.com, which helps people with dosage programs and some basic information about how to get good results with cannabis, maximizing the benefit and minimizing the potential harm. And then we also have products. So Healer has hemp products, including CBD and CBDA products. And then also we are launching a CBG product, which I will tell you more about tonight. For those of you that are interested in the Healer Certified Training Program, you can get a $50 discount with the code webinar. So $50 off for that. For anyone that wants to purchase our CBG drops, the code CBG will give you a 20% discount on that. Also, I like to put in a plug for my book, The Handbook of Cannabis for Clinicians. If you are a clinician, this book is for you. If you're not a clinician, it's probably not the right book for you. And actually, Bonnie's book would probably be better because it's kind of written to anyone. Bonni Goldstein is our guest tonight. I'll introduce her in just a moment. But wow, I think that's about it. So the format of the webinar tonight is that we're going to spend probably about 45 minutes talking about, tonight we're going to start with some of the basic science around CBG, and then we're going to dig into all the latest, everything that I could find basically that I thought was relevant, published about CBG, and even some things that have not yet been published. And that's probably from within the last 6 months or so. Then we can take a little stretch break and spend the rest of the evening, maybe another 45 minutes or so, answering questions and having a dialogue, because tonight's focus is CBG, and I think we have a lot to learn about CBG. It's very new, and nobody's the expert, but having Bonni here, she probably has more clinical experience with it, definitely more than I do, and probably more than many people, even though I think we're all still learning a lot. So Bonni Goldstein, for those of you that don't know her, and I'm sure that most of you do, she is a cannabis clinician, expert, educator, author, and dear friend. And really my secondary motivation for having you tonight, Bonni, is we don't get to hang out at conferences much anymore. And it's important for us to have these conversations about what's happening with our patients and in our practices. And I feel like this community could benefit from overhearing our dialogue on this topic. Bonnie's background is in pediatric emergency medicine. She's come a long way since then, treating adults and children. She's located in the Los Angeles area. And anything else I should mention about your practice, Bonni?
Nope. I think you covered it all.
Okay. All right, great. Well, I am going to share some slides. Oh, and then for everyone that's watching, we're happy to entertain your questions. We got some questions submitted ahead of time, and we'll make sure we hit those. But you can submit questions in the chat, and we'll keep track of those. You can raise your hand. We really love live questions where we're able to dialogue with you. But if you want to just submit a text question, we're happy to field those as well. However, during the slide presentation, I know I don't have enough attention to watch chat and speak and watch the slides. Bonni may or may not. And so don't expect us to respond if you're just chatting during the slides, but we can come back to those questions afterwards. So I'm going to get the slideshow started. Great. So the topics for tonight, we have a review of the mechanisms of action of CBG. Let's see, I'm kind of lost the window with everybody. There we go. And then we're going to jump into some of the newer research. So we'll look at the effects of CBG in a mouse model of PTSD, a study in mice on CBGA and its potential anti-epileptic effects. Another study that's just a cancer cell study looking at CBG in brain cancer. A study that looked at the anti-inflammatory effects of CBG and CBD, both alone and in combination, in a model of lung inflammation. And then a case series of CBG and CBD in patients with Parkinson's and Lewy body dementia. And before we dig in, I just want to give a little remembering of another clinician in the field who recently passed away. That's Alan Frankel. I wasn't very close with him, but we had some really wonderful conversations at conferences. And from time to time, he helped me with some insight. And so I was really thankful for him. And I know that he helped a lot of patients and was very caring to his patients. And so he passed away recently. And so I just thought we would remember him. And then also, let's move on from that. So, and then here's some images of our hemp farm here in Maine. It's not my farm, but it's where Healer derives its starting material. And you can see I'm pictured in the back with Brad Foyer on the left. He's the CEO of Healer. And in the middle is Ben, our lead farmer. He runs this farm. It's called Sheepscott Farm in central Maine. And you can see some healthy looking plants there. And then our newest product is the Healer CBG drops. It's around 50 milligrams per milliliter total cannabinoids, similar to our CBD products. And again, we have this kind of 6-to-1 neutral versus acidic ratio. So it has a decent amount of CBGA in there as well. And again, discount code CBG will get you 20% off. So let's start at the beginning with CBG and Bonni, and then also Ethan, if you're interested, I'm happy to take any comments. But so CBG has been considered or called the mother of the cannabinoids, or the stem cell cannabinoid, and I think that comes from really the CBGA. So the plant takes these two precursors and converts them into CBGA. And then typically the CBGA is pretty quickly converted into the other acidic cannabinoids like THCA and CBDA. It could also be converted via heat and decarboxylation into CBG. And as many of you know, THCA is the precursor to delta-9 THC, CBDA is the precursor to CBD, and so forth. And so what's happened recently, just in the last few years, is that breeders have been developing varieties of plant that lack these enzymes almost completely. So the THCA synthase and the CBDA synthase, when they're not present, CBGA will accumulate in the flowers. So up until now, the only real way to get any kind of decent amount of CBG or CBGA in flowers was to kind of use horticultural practices and harvest early, which would decrease overall yields, and you still wouldn't get much CBG, even though I've seen people, strive for that and get, low amounts of it in the final product. But now with these varieties that lack these enzymes, high levels of CBG can be obtained. And so this is something that people have been exposed to through their use of cannabis and hemp for a long time, but until recently, never at very high quantities, or at least not as the dominant cannabinoid that they're exposed to. And so something new to learn from it. Now, there were two review articles, or one is a chapter and one is a review article that are recent. This one on the top right, the pharmacological case for cannabigerol. This came out in this year in 2021. And then there was a chapter that I found useful in this textbook, which has a terrible name, even though there's some good things in the textbook. And this was from 2017. And this was another review of CBG. And it was these two review articles that I used to gather the information about the mechanisms of action. And so this is what I want to talk about first is, how does CBG work in the body? And so let's start out. First of all, it's been shown to readily cross the blood-brain barrier, at least in rodents. And so it probably does that in humans, certainly seems like it does. As far as the main targets of THC, the CB1 and CB2 receptor, it seems like CBG is a bit more like THC, at least in comparison with CBD, because it does have some partial agonist activity at these receptors like THC does, but a much lower binding affinity. And different studies have found it to be anywhere between 5 and 27-fold lower affinity than THC. So it does have a little bit of activity at CB1 and CB2, but it might require large doses of it to get a significant amount of activity to make a difference, but could be a really nice synergistic effect with THC and perhaps with our own endocannabinoid system. It affects many ion channels, like so many of its sister compounds in the plant. So CBD and CBG are very comparable at TRPA1, TRPV1, TRPV2, and so forth. Of note here, the TRPV1 receptor, also known as the capsaicin receptor, which is a target that can affect pain and inflammation and have some psychiatric effects as well. TRPM8 has received some attention in a treatment for prostate cancer. It seems like prostate cancer cells can be susceptible to TRPM8 agonists. And, we have a lot more to learn about that. But in terms of these ion channels, CBD and CBG have a lot of overlap. So here's where things get new. The alpha-2 adrenoceptor, which is a G protein receptor that sits kind of like the CB1 receptor on the presynaptic terminal. So we have an image of a nerve synapse here. We have the presynaptic nerve and the postsynaptic nerve. And typically in the cannabis world, when we show this, we're showing how the endocannabinoids are kind of these negative feedback messengers to get the presynaptic nerve to stop releasing its neurotransmitter. Now this model looks very similar, but what we're seeing here is not an endocannabinoid effect, but it's actually directly a norepinephrine effect. So this would be a part of the sympathetic nervous system. That's the fight or flight nervous system, one junction here. And we have depolarization, and we have this presynaptic nerve releasing norepinephrine. The norepinephrine will stimulate the alpha-1 receptor on the postsynaptic nerve. And then it also, when there's enough of that, when the levels in the synapse are high enough, it will stimulate the alpha-2 receptor. This alpha-2 receptor then shuts down the release of more norepinephrine. So it's another negative feedback mechanism. Now, especially in the periphery and probably also in the brain, the CB1 receptor can serve this purpose. It can, when there's excessive amounts of norepinephrine, the peripheral cells will produce anandamide, which will be another way of shutting down further release of norepinephrine via the CB1 receptor. But this target, alpha-2, is very interesting. When it's stimulated, it decreases the activity of the sympathetic nervous system. One study that compared it with the drug clonidine, which is a very old blood pressure medication. It's known to have this same effect on the alpha-2 receptor. And one computational, so kind of like a computer simulation of CBG, predicted it would have a higher affinity at this receptor than clonidine. Now, clonidine used to be indicated, well, I guess it still is, as a treatment for blood pressure, but it's probably one of the most commonly used drugs off-label, which means it's used for a lot of other things besides blood pressure. And it's not that great at blood pressure. It's got some other targets in the body, and it's kind of erratic. It can be too strong for blood pressure, not very consistent. But what it's used for a lot is conditions where there's too much fight or flight nervous system activity. And I'm sure that, I see a lot of its use in autism spectrum disorders where there's aggression and agitation. And it can work quite well in that setting. But really anywhere when the sympathetic nervous system is overstimulated. So it's used in opioid withdrawal. It can be used as a treatment for PTSD or anxiety to settle down that fight or flight system. And then there are different subtypes of this alpha-2 receptor, and they do different things. And we don't know what CBG does in terms of these different subtypes. So it might be very similar to clonidine, or it might be a little bit different. And so, we'll have to learn more about this. But what we do know about this target is that CBG might be useful for treating blood pressure, pain, especially sympathetically mediated pain, attention deficit disorder. There's another drug that acts on this alpha-2 receptor called guanfacine. It comes in an extended release, and it's approved as a drug for treating ADD and ADHD. It has less blood pressure effects than clonidine. I see that used a lot. When it works, it's nice because it can be an alternative to stimulant medications. CBG might be useful for opiate withdrawal symptoms, tic disorders, PTSD, dementia, and so forth. So, and this is a target that we don't see a lot of action with the other cannabinoids. So this is kind of something new. Now, looking at the serotonin 5-HT1A receptor, we see, again, something kind of new. CBG has been shown to be a neutral antagonist. It blocks both agonists and inverse agonists. And so it kind of blocks some of the activity at this receptor. Compared to CBD and CBDA, these are indirect agonists. They end up stimulating this receptor, and that's been shown, at least in animal models, to be the mechanism of action behind the anti-nausea effects, the antidepressant, anti-anxiety effects. And so kind of an opposite function between CBG versus CBD and CBDA in this regard. Unlike THC and CBD, CBG has not been found to have antiemetic or anti-nausea, anti-vomiting effects. And it's also been shown to oppose some of the anti-nausea effects of CBD, which is the little bit of evidence that this theoretical opposition between CBG and CBD might be real. You know, I think, you know, I first put it out to the Society of Cannabis Clinicians and to Bonni, hey, has anybody reported trying to take CBG and CBD together and finding that the CBG cancels out the CBD? And I didn't really hear much about that. And if any of you watching tonight have had that experience, I'd love to hear about it during the questions session. But I think it's possible that some of the benefits of CBD could be counteracted by enough of CBG. We'll talk more about, you know, recommendations that follow from there. Now, another really interesting thing is that this 5-HT1A receptor is located both pre and postsynaptically, if you think about that image that was shown before. And the downstream functions of the receptor vary based on what type of neuron it is and where the neuron is. And so I know this sounds really counterintuitive, but a selective antagonist of this receptor has been shown to make the effects of an SSRI, the common class of antidepressants that raises serotonin levels, it can make it more strong. So I know this sounds strange. How could a drug or a research molecule that blocks this receptor, how could it make the selective serotonin reuptake inhibitor activity stronger? And again, that depends where the receptor is, probably the subtype of the receptor and so forth. Another antagonist was found to enhance the effects of several different classes of serotonergic antidepressants in human patients with major depressive disorder. So it's not just animal evidence, there's some human evidence. I know this is getting really confusing, but I guess what I'm suggesting here is it's possible that CBG could block some of the benefits of serotonergic agents like CBD or like some antidepressant drugs, but it's also very possible that it could actually enhance and make these effects more potent. And it could depend on the individual, the drug, their physiologic situation. So certainly a potential for interactions here. Probably not dangerous interactions, but interactions that could increase or decrease the effectiveness of a treatment. And so unpredictable effects on concurrently administered psychiatric medications and potentially on CBD. This is why I'm suggesting we have a lot more to learn here. Now, turning to the inside of the cell, so we're no longer on these G protein coupled receptors on the cell membrane, we're on the nucleus of the cell. The PPAR gamma nuclear receptor is a receptor that controls the expression of genes that are related to metabolism, inflammation, sometimes pain, bone remodeling. And so this CBG has a stronger affinity to PPAR gamma than both THC and CBD, and therefore has potential to improve symptoms and the pathology of metabolic syndrome. And in one in vivo or rodent study, the effects of CBG were enhanced by CBD. The kind of anti-metabolic syndrome effects were enhanced by CBD. So these two could potentially work well together in certain situations. And then CBG has been shown to be an anti-inflammatory. Both CBG and CBGA were shown to inhibit the COX-1 and COX-2 enzymes more powerfully than THC. You can see in this graph here, percent inhibition. Now, these are enzymes that produce inflammatory signals in the body. So when you inhibit the enzymes, there's less inflammation. And you can see the signals down here at the bottom for CBG and CBGA were stronger even than CBDA in terms of COX inhibition, and stronger than THCA. And we tend to think of THCA and CBDA as these strong anti-inflammatory aspects of cannabis. Perhaps CBG and CBGA are even stronger in some settings, especially related to these two enzymes. And then also not just inflammation in the peripheral tissues, but also inflammation in the central nervous system via its activity in the endocannabinoid system. So it's been shown that CBG can inhibit an enzyme called NAAA, which hydrolyzes palmitoyl ethanolamide, PEA, which is an endocannabinoid-like molecule, and it also hydrolyzes other fatty acid ethanolamides. CBG has also been shown, and so basically inhibiting this enzyme would lead to higher levels of PEA, and PEA has been studied. It's actually available over the counter as a nutraceutical product with anti-inflammatory, anti-pain, and other benefits, anti-mast cell activation. Then CBG also inhibits anandamide cellular uptake and the enzyme MAG lipase, which breaks down our endocannabinoid 2AG. And so we've got some indirect activity in the ECS here that could decrease neuroinflammation. CBG has been shown to have antibacterial properties. It's among the most potent cannabinoid tested against antibiotic-resistant strains of Staph aureus. In one study, compared to conventional antibiotics, it had a lower minimum inhibitory concentration than the antibiotic norfloxacin in 5 out of 6 strains tested. It was more potent than erythromycin, tetracycline, and oxacillin in at least one resistant strain. So for something that's so seemingly non-toxic, that could have these antimicrobial effects, that could be important. And then in a mouse model of Staph aureus infection, one study showed that CBG was effective at reducing colony-forming units as vancomycin, which is a strong antibiotic that's used commonly for that type of infection. So not just like some antimicrobial properties, but comparable to antibiotics. And then pain. So CBG probably works mostly as an analgesic via its activity at that alpha-2 receptor we discussed earlier and via its anti-inflammatory effects. But there's many other targets that can modulate pain listed on this slide, but not tested. So these are all theoretical. There was one rodent study where CBG was shown to be much more potent than THC and aspirin. It was a model of peripheral inflammatory pain. And so here in this bottom of the slide here, you can see the ED50, which is the effective dose in half of the animal subjects at reducing pain. And you can see the dosage of CBG was much lower than THC. CBG worked at 1.26 milligrams per kilogram, whereas THC worked at 25. Now, THC reduced pain more. You could keep cranking up the dose of THC and eventually get 100% reduction of pain in this model. This was the most you could get from CBG, but this occurred at a very low dose, which tells me that, for rodents, this is very low. So CBG could be a good agent for pain, and certainly without the impairment possibility related to THC. And then inflammatory bowel disease. One mouse model of colitis found that CBG was protective and curative, and that's measured by reducing colon weight and length, the ratio of weight to length, which basically tells us how inflamed it is. Now, this DNBS, this model of colitis, increases some of these inflammatory cytokines and decreases IL-10 levels. CBG restored these to normal levels in the study. So it looks like via modulating these inflammatory signals and the way they're produced and the amount of them, it can decrease inflammation, and probably not just in the colon. CBG restored superoxide dismutase antioxidant protection, which is another mechanism of action for protecting the cells in the intestine. So it could be a lot of promise there for inflammatory bowel disease. And then cancer. Like many of the phytocannabinoids, CBG was reported to reduce cell proliferation in many types of cancer. Several findings suggest it may be more relevant for prostate cancer than some of the other phytocannabinoids. I know in the work that came out of Israel a few years ago, where many different types of cannabis were tested against many different types of cancer cells. In some of the formulas, they found, and this is Dedi Meiri's work, they found that different products that had the same amount or almost the same amount of CBD and THC could have very differing effects on the viability of these cancer cells. And probably two of the most common reasons found for those varying effects, one was CBG, another one was THCA, the presence or absence of CBG or THCA. So it might be an important part of cancer treatment. In terms of glaucoma, CBG's chronic and to a lesser extent acute administration has been shown to reduce ocular tension in cats, so the pressure in the eyes. The intraocular pressure of the CBG treated eyes was 4 to 8 millimeters of mercury lower than the untreated eye on the other side. That's a pretty significant reduction that could be important treatment for glaucoma. And it was shown not to be toxic to the eye or to the optic nerve. And so this is a diagram from that textbook that just kind of sums up the mechanisms of action in terms of what we could do with these mechanisms of action. So CBG, as we mentioned, reducing pain and inflammation, having anti-cancer effects, anti-glaucoma, anti-inflammatory bowel disease effects, antibacterial for infections, also some evidence suggesting it could help with psoriasis, bone healing, neuroinflammation, testosterone imbalance. It has some weak anti-androgen effects. I don't know that those are going to be clinically relevant, but we'll see. And then also some potential in mood disorders. So that is a quick summary of a lot of different things that CBG does. And next, we're going to move into some of the studies. But before I do that, I'm curious, Bonni, if there's anything you want to comment on, or Ethan, anything to add at this review, this summary?
No, excellent summary. It's what's interesting about CBG, which is the same as what we're seeing with CBD and to a lesser extent some of these other cannabinoids, is this, what we call promiscuity, not really selective, hits multiple targets, which translated to a clinical application makes it difficult to guess how a patient is going to respond. So that is why when people ask, well, how come it didn't work for me? Or how come it works great for me, but not for somebody else with the same condition? You have to remember that there's a lot of different targets and your underlying baseline chemistry matters, right? And so if you don't, and most of us don't really understand our baseline chemistry necessarily on a cellular level. So I think when introducing CBG, you do the same thing as you do with everything else. You start low, you titrate up, and you look to see how you feel specifically, looking for the desired effects and looking for those effects that maybe aren't so desired, and then trying to narrow in on the best dose.
Thank you. Yeah, it's we have a lot to learn, and what we learn is probably going to be different for different individuals. Like most of the other compounds we talk about, THC and CBD included, CBG has the potential to lower blood pressure via this alpha-2 receptor. I'm wondering, Bonni, because we're not going to talk about it in the subsequent slides, but have you seen that at all clinically, CBG having an effect on blood pressure?
No, I have not seen that I have seen some children with autism get an opposite reaction, but it seems to be that kind of biphasic, bidirectional. They're not at the right dose. Yeah. So sometimes it seems like they're overstimulated at that low dose, and then the higher doses are more calming. And again, it depends on the person and their underlying chemistry. But no, I haven't seen any issues with blood pressure.
Okay, I keep seeing it come up, and so I suspect that Catherine Fairfield has a very pressing question for this part of the webinar instead of later during the question session. And so I'm open to hear that. I'm going to unmute you, Catherine, or ask you to unmute. And if your question's relevant to these mechanisms of action, I'm happy to take it now. Or, oh, there you go.
Hi.
Hi, we can hear you. Yes, we can.
I'm just, geez, I don't know. It's a lot of information, and I'm just trying to figure out how to get my pain from my back surgery, which seems to be muscle related. A doctor told me that I had to see. Would one certain tincture be better than another?
Yeah. Okay. So, you know, a complex question because, you know, pain comes from different sources, and different, even two people that have similar types of pain might respond differently to two different treatments. You know, I think still I'm suspecting that THC is going to be the best pain reliever that the cannabis plant has to offer, especially milligram per milligram. And that's in general, but I think that some people do well with more of the anti-inflammatory compounds like CBDA, THCA. Some people do well with CBD for pain, even though I think that's a lot less common. And then CBG, I think, is something new to try. So if we, you know, work to kind of get you fine-tuned in terms of your THC and CBD dosing, and you weren't satisfied with that, it might make sense to do a trial of CBG, and kind of like Bonni said, starting low and going slow and seeing how it affected you. I think it does hit pain targets that are distinct from CBD and THC, certainly.
Okay, so can you take two tinctures together? Like, would it make sense to take just a little bit of the THC and
the CBG?
then,
yeah, I think right now
what I have right now is CBDA.
Yeah.
So mixing those two, does that sound
smart?
Yeah,
I think that using THC and CBDA together, and then if you weren't satisfied with the results and wanted to see if you could get more pain relief, I think that it would make sense in some cases to add CBG to that. I'm curious if you have any comments on that, Bonni, but or Ethan, but or if you've got any experience with people doing that.
I often, you know, how the way I practice is very methodically. You start with one, you ramp up dosing, you see if you can find your best spot. Then if you find something that helps, you find the best dose, then you add something else if there's still room for improvement. Same thing, start low, titrate up, see if you can find a sweet spot where you get both, right? And if something is not helpful at low and high, you jettison it. Put it on the back burner, maybe come back around to it at a later date, a different chemovar, a different product within that group. So I'm very methodical. You have to take notes, so you should be journaling. And also it would be helpful if you had somebody helping you who understands these compounds. But the other thing is that it takes time.
Yeah, thank you. That's really good advice, Bonni. I appreciate that.
Dustin, I'd like to jump in if I could real quick.
Please.
The nausea issue, the possibility of CBG complicating the antiemetic effect of CBD. In our survey, we had a high level of endorsement for CBG improving nausea, and actually better than in comparison with conventional drugs. So at least so far, I know a lot of these preparations that were used were likely mixed, CBD, CBG. So far, we haven't seen this problem in humans. The study that was cited was an animal study, and you know, it could be that things are quite different. But so far, so good on that issue.
Yeah, you know, amongst colleagues, I really wasn't able to find anyone with like even one case that thought that CBG counteracted CBD. And at the end of this presentation, we'll look at some cases of Parkinson's and dementia where they seem to work well together as well. So it's kind of a theoretical idea that they might work against each other. And I agree, probably they don't. It might be interesting for people that are adding CBG to try both spacing it apart from their CBD or CBDA and taking them at the same time and seeing if they notice a difference there. And that might be like a 4-hour window, you know, like take one, wait 4 hours, take another, and compare how that feels versus taking them together. But I'm curious. We have a lot more to learn about that. Ethan, any comments on this strange, like 5-HT1A antagonist potentiating serotonergic drugs?
I'm not going to claim to understand it. What you said was exactly right. There's seemingly these paradoxical effects, and you know, the idea of counteracting 5-HT1A sounds bad, but in practice, we're only seeing good things in this regard. So I can't explain what's going on at a neurophysiological level, but so far it seems all good.
Okay, very good. Well, let's move on to some of the newer research. And so to begin with, this is an interesting study. I put it first because I found it surprising. And again, this is an animal model. A lot of these animal models do not translate to people, especially people that are taking multiple compounds that can work synergistically together. But this is basically a model of PTSD in mice. It assesses the effects of repeated, well, in this study, they assess the effects of repeated CBG exposure on long-term fear memories, looking at the expression of these fear memories, the acquisition of them. So like, you know, just to put this into terms of PTSD, how traumatizing is this experience? Does it create this fear memory that affects behavior moving forward? That would be acquisition. And then how strongly does it impact that behavior? That would be the expression. Consolidation has to do with when they have this traumatic experience, how likely are they, or how quickly do they kind of consolidate that into their long-term memory storage? How is it made a part of their memories? And then reconsolidation would mean like if they're re-exposed to a cue or a trigger or re-traumatized, does that fear memory get enhanced? And so there's animal models of this where basically a mouse is put into a cage and shocked in its feet. I'll show you how that works in subsequent slides. But basically this is a model that has shown both THC and CBD to be effective in some of these measures, basically having anti-PTSD effects. And it's not just anti-anxiety effects. It's CBD and THC have been shown to disrupt the process of acquiring PTSD, and in some cases to speed the healing of PTSD or the fear extinction. So, so this is how it works. And this was the first test that was described on long-term fear memory. And so basically what this little diagram shows is that the mouse is put in a cage with a wire bottom. It receives a shock through the cage floor. 12 hours later, it starts receiving CBG. It receives CBG daily for 21 days. Then 72 hours go by to make sure the CBG isn't still in the system. And then the mouse is put back into the same cage, and they look at, does the mouse freeze up when put back into that same cage? If it freezes up, this is an indication that it remembers how painful this cage was 5 days ago or whatever. And so you can see here that the percent freezing, so this is a control group that didn't get the shock, no shock in vehicle. This is shock in vehicle. And you can see if they froze about 40%. So no CBG was administered. And then in this one, 10 milligrams per kilogram of CBG administered. And in this one, a higher dose, 30 milligrams per kilogram. And what you can see here is there was no change. CBG did not change this retrieval of the long-term fear memory, even after 21 days of treatment. No change in that test. Here's one on fear memory acquisition. So the CBG is given before the shock, 2 hours before the shock, the rodent's shocked, 24 hours later, it's put back in the cage. How often does it freeze? You can see here there was no significant difference at any of these 3 doses of CBG. So CBG didn't seem to change fear memory acquisition either. Another study looking at fear memory consolidation. So the rodent is shocked, it immediately receives CBG, and then 24 hours later, it's put back in the cage and looked at how much it freezes. So this is testing, well, if we give the CBG right after the trauma, does it prevent that consolidation or that long-term storage of this traumatic memory? In this model, again, the answer was no. CBG at 3 different doses didn't really seem to do anything. And then as far as reconsolidation, so the rodent is shocked. The next day, CBG is given 2 hours before putting it back in the cage. So this is how able is it to retrieve the memory of being shocked yesterday. And CBG, again, did not change that at all. It didn't make it any less likely for the rodent to freeze up and therefore, didn't change the retrieval of the fear memory. And then kind of a different model here using the light dark box. This is looking at anxiety. So the rodent is shocked. 24 hours later, it's given CBG and then put into this cage where it can spend time in the light or spend time in the dark. And I'm not going to go into detail about all of this, but essentially it didn't change anything. It didn't change the trauma-related anxiety behavior of the mouse either. And so, let's pause here and talk about CBG and PTSD. Now, again, this is just an animal model. I think humans with PTSD are way more complex and might have more aberrant autonomic nervous system activity that CBG could potentially help with, compared to a rodent. But this study at least suggests that CBG is different than THC and CBD when it comes to trauma and trauma-related anxiety. Any comments on that, Bonni, or have you seen anybody using CBG for PTSD symptoms?
I have not treated anybody with PTSD with CBG. I find the best results usually either THC or CBD or a combination thereof. And after this, I probably would think twice again before doing it, but certainly somebody who might have a treatment resistant to THC and CBD, I would try it only because I have seen many patients with anxiety do well with CBG.
Yep. Okay, thank you. Let's move on. This next one is about CBGA. And the author started, again, so this is the acidic precursor to CBG. It gets converted into CBG when it's heated. And so in this study, and by the way, I've presented many studies in the last year, webinars from this group. It's a group in Australia that's really listening to clinicians like Bonni and myself and has been very interested in the acidic cannabinoids and different approaches using cannabis to treat epilepsy in their animal models. And so they first screened several of these minor cannabinoids in mouse models of Dravet syndrome, which is a severe seizure disorder. They looked at all the ones you see here on the slide. And they found some promising results with CBGA. They took that further and then tested it in 2 other seizure models, one called the maximal electroshock model, and then the 6 Hertz threshold model. And then also tested for spontaneous seizures in the Dravet model. The first Dravet model has to do with temperature. The second one is just looking at spontaneous seizures. And then they looked at the targets of CBGA. And so this brought some new information that I think is worthwhile. So first of all, this is the screen of all these different minor cannabinoids in this Dravet model. And basically they raise the temperature of the rodent. The rodent has a genetic change that affects this sodium receptor and sodium channel. And as the animal gets hotter and hotter, eventually it's going to have a seizure at a certain temperature. And if it's able to withstand higher temperatures, that means that the agent might have more strong anti-epileptic effects. And so you can see over here, they make it a little hard. Each cannabinoid has 3 bars, right, at 3 different doses. So you can see CBDV, for example, had some anti-convulsant activity at the medium dose, but not at the low or the high dose, not significant anyways, which is interesting. CBDVA had anticonvulsant properties at a very high dose, 100 milligrams per kilogram. CBG didn't have any in this model. CBGA had anticonvulsant properties both at 30 and 100, and so forth down the line. THCV actually had some proconvulsant effects at a certain dose. A lot of you are probably, curious to see, wow, the same agent, the same cannabinoid at one dose can make seizures worse and one dose can make seizures better. Well, welcome to cannabis. That's, pretty normal, actually, even though it seems abnormal. In this model, in a previous study, CBD was effective at 100 milligrams per kilogram. And so you can see CBGA, at least in this model, seems to be more potent because it was effective at 30 milligrams per kilogram. And that's why the researchers became interested in it and did some further studies. So that was temperature-induced seizures. The next thing they looked at was spontaneous seizures. And they gave CBGA in two different ways. One injected into the abdomen, IP, at 3 different doses. And then the other was just added to their food at a fairly high dose. But the expectation is that less is absorbed by eating it versus having it injected. And so you can see it's a much higher dose added. They also looked at the blood levels of CBGA and found that to get the equivalent of 100 milligrams per kilogram injected, they needed 2,500 milligrams per kilogram in the chow. And so those achieved similar blood levels and in theory, similar brain levels, even though they didn't test that. Looking at the seizure frequency, again, these are spontaneous seizures. It seems like the high dose of CBGA resulted in more spontaneous seizures, not less, an unexpected finding. The low dose was not significantly different from the untreated animals, but those that received the high dose of CBGA on average had more seizures. You can see there were fewer of them that had 0 seizures in the high dose treatment group. And then the other thing that was kind of surprising is that the animals that were treated with CBGA at both doses had less survival. More of them died. And you can see a pretty steep drop off here after about 3 weeks of treatment. So, some warnings there. CBGA might not be great in some types of seizures. And, I think in human patients, people would probably notice that and not necessarily continue the treatment if it were making things worse. So I'm not suggesting this is going to be killing patients with epilepsy, but it's still interesting to note that this was the effect in this one model, just one model of one severe type of seizure disorder, and this cannot be generalized to all types of seizures. CBGA was shown to increase the anticonvulsant efficacy of clobazam, brand name is Onfi, against thermally induced seizures and spontaneous seizures. So this is a common drug that's used in Dravet syndrome. It is a atypical benzodiazepine, and so it works via the GABA signaling system. And because CBGA is a GABA reuptake inhibitor, it may be potentiating this drug. The way that to read these is, again, here we're at temperature and seizure occurrence. And you can see that when clobazam was given on its own, it raised the temperature threshold a little bit. When CBGA was given, it didn't change the temperature threshold much, but when they were given together, you see the best results. So that was temperature-related seizures. Here are the spontaneous seizures. And again, in the combination treatment, you can see they're clustering much lower. That was statistically significant, and no real difference in survival amongst the 3 groups. And then changing models, the maximal electroshock model, CBGA had biphasic anticonvulsant effects where at just the right dose, it did raise the threshold for seizures. So it had an anticonvulsant effect, but at too low of a dose and too high of a dose, it didn't do anything. It's just so strange, but it's pretty common. So I'm used to it now. So a different seizure model, maybe the right dose of CBGA helpful. And then in the 6 Hertz seizure model, 2 doses of CBGA were shown to be proconvulsant, making seizures worse, whereas the higher dose did not make seizures worse. Yes, I mean, these are really their findings, head scratchers, but something is happening at the lower doses that isn't happening at the higher doses. Strange. So what else did they find? Well, they looked at the mechanisms of action, and they showed that CBGA is a non-competitive antagonist of GPR55 at concentrations that are relevant to the brain. Now, this is thought to be one of the anticonvulsant targets of CBD. So potentially CBGA and maybe CBG, they didn't test it, but CBGA might be acting similar to CBD in terms of seizures. CBGA showed the positive allosteric modulation of GABA A. So it's not just a reuptake inhibitor, but it's actually making the activity at that receptor stronger. This probably is another part of its synergy with the drug clobazam. Prolonged exposure to CBGA in their studies resulted in the not downregulation, but desensitization of this receptor, which would potentially explain how a high dose could kind of diminish the therapeutic benefit. Basically, if you desensitize the receptor, it might not be active anymore. And so maybe too much of it, if it's too strong, it kind of backfires. CBGA also showed inhibition of TRPV1, but not likely at relevant concentrations. So let's let that kind of kick off our conversation on CBGA and maybe CBG also in terms of seizures. Now, I'm pretty new to CBG. You know, I haven't been using it with my patients much. I've had one case so far that seemed to be pretty dialed in with CBD and THCA. I suggested, the child, I think, gosh, he's about 12 now. He was still having infrequent seizures. He had gotten a lot better on these other two agents. I had suggested adding CBG as more of an approach for his behavior, which was hyperactive and somewhat agitated. And it turns out that after adding CBG, the seizures went away completely. That's my one case of anticonvulsant effects with CBG. What about you, Bonni?
That's funny. I have a very similar story. A teenager with a longstanding history of seizures who had a significant reduction of seizures with CBD and low dose THC and low dose THCA, but still was having, I would say she went from probably around 50, 60 seizures a month down to maybe 10. And we added CBG to help with kind of the breakthrough behaviors to see if it would help with anxiety, despite being on all these other compounds. It just tells you how neuroexcitatory her brain was. But adding CBG, she's the only patient, we saw another 75% reduction of seizures, which is always very hard to explain. Is it because the product had maybe a terpene in it that might help her? Is it the CBG? It's hard to explain, but she had that result. I have not seen seizure reduction with the addition of CBG in any other patient who still was having, who's been on cannabinoids for seizures and still had room for improvement. So adding, it's not what I go to it for behavior and anxiety, but because of that one case, it is still on the list, and I will still add it in once we kind of get through the other cannabinoids.
Thank you. All right. Any other comments about seizures and these compounds, Ethan?
Yeah, sure. CBGA, no comment, but boy, I'd be real hesitant after seeing the animal data. With CBG, in our survey, we only had a few people that commented, and it wasn't statistically significant. So I don't think it would be a go-to agent in this instance, but it has plenty more to recommend it.
Great, thanks. All right, let's move on to another study. And this is looking at cancer cells, specifically glioblastoma cells. And so the title, as you can see, suggests that CBG is a potential therapeutic agent in this type of cancer. I had a new patient with glioblastoma today and also a new one last week. It is the, so what can we say about glioblastoma? It is the most common, it's one of the most aggressive cancers and also one of the most common types of brain cancer. And the standard therapy for it, which is radiation plus temozolomide, typically only prolongs survival by about 2 months. It's a It's a very deadly cancer because for a couple reasons. The tumor itself tends to have these glioblastoma stem cells inside of it. And so those are highly resistant to our current treatment. And so even if the treatment kills the cancer, these cancer stem cells can then create new cancer and actually cancer that's adapted to the treatment. The other part of this being such a difficult type of cancer to treat is the way it invades the brain. Really gets in there and is very hard to remove it completely using surgery. So other animal studies have, and some human data has shown that THC, CBD, and combinations of the two have anti-glioblastoma effects. No previous testing with CBG on this type of cancer. So this is the first study that's looked at that. They were using pure cannabinoids, not whole plant type preparations, using established research-based glioblastoma cell lines. And then also they obtained about a dozen cell lines from individual patients. And I think that, adds to the how informative this is, because again, with these glioblastoma stem cells, there's the cancers can be very different from one patient to the next, even though it's the same type of cancer. And they did the test both on the differentiated cancer cells and also on the glioblastoma stem cells. So let's just dig right into the results. Basically, the viability of both the glioblastoma cells and the stem cells were significantly reduced by all three of the cannabinoids. CBD was the strongest. And so you can see what these numbers are showing are the concentration required to kill or prevent life in about half of the cells present. And so you can see the average required for CBG was 28 micromolar, for CBD 22 micromolar, and THC 27. So pretty similar, but CBD was the most potent. And then looking at the stem cells, you can see again that CBD was the most potent. CBG was less potent there. So it definitely had some anti-cancer activity, but not quite as strong as the others. For those of you that are curious, it's the U87 and U373 and the K26 that are kind of the standard research cell lines, and all these NIB ones are the ones they derive from patients' biopsies. So that was cell viability. Then they were also, the CBG was also tested on cytostatic effects. So this isn't about killing cancer, it's just about preventing cancer from dividing and growing, from preventing the cells from replicating. And what the study looked at is how the percentage of cells that remained in this G1 or S phase versus G2 and M. And so I'm going to explain that a little bit using this diagram. After a cell divides, not just cancer cells, but any cells, after it divides, it goes through this first growth phase called G1. Then it goes through an S phase where its DNA is being replicated. So it's kind of doubling its DNA. Then it goes through another growth phase after that, which is followed by the cell division. And then it starts over again. And so if a higher percentage of the cancer cells get stuck in G1 or S, that's a good thing. They get stuck there. It means they're not going to continue and divide. And what the study showed in 3 of the different cell lines, this is, on the left is the vehicle, and on the right is CBG at 25 micromolar, which is similar to the concentration needed to decrease viability. There was a shift in the amount of cells that got stuck in the G1 phase. You can see 64% to 85%, 51 to 67, and 61 to 76, suggesting that CBG at the same concentration where it can decrease the viability of the cells, in other cells, it could also prevent it from dividing and prevent the tumor from growing. They also looked at apoptosis, which is a closer look at how it's doing this. Is it causing these cancer cells to kind of self-destruct? Another thing, that's better. It creates less damage and less inflammation in the body, better than necrosis, which would be just the cell kind of dying and spilling its contents and making a mess for the body to clean up. Similar results to THC and CBD if you look at CBG. But the glioblastoma stem cells were more sensitive than the glioblastoma cells. And this suggests that CBG's impact on the viability is probably largely due to its effect on these stem cells. And that's important because these stem cells are highly resistant to treatment. And so if we have a non-toxic agent that can cause apoptosis in these stem cells, that could be very important. Also in this study, it was shown that adding CBG or TMZ, which is temozolomide, it's the standard treatment, the standard chemotherapy treatment for this type of cancer, adding those to CBG enhanced its apoptotic effects. So, and you can, the other thing I think worth pointing out on the slide is we've got 4 different types of glioblastoma, all the same type of cancer, but just 4 different cell lines. And look at how different the effects were. I mean, CBG caused apoptosis in almost 50% of this one and just about 0 of this one. So it could really differ from one person to the next, and one cancer cell line to the next. Okay, and then we're not going to go real deep into this image here, but the combined effects. So looking at combining CBD and CBG at different doses, what they found was that there were additive effects, not synergistic, not like multiplicative, but additive in both the glioblastoma cells and the stem cells. The viability of the stem cells increased at very low concentrations, below 10 micromolar for CBD and 5 micromolar for CBG. Interesting, so at higher concentrations, it decreased viability, but at lower concentrations, it seemed to stimulate viability. That's a bad thing, right? We don't want to enhance the viability of these stem cells. The authors suggested, based on a previous study, that it's possible that what's happening is the cannabinoids are increasing the differentiation, meaning the conversion of stem cells into mature differentiated cancer cells. And that's part of what's kind of confounding these results and showing that it's increasing the viability because it's driving that differentiation process. Hard to know, but I like to point it out. We have all this data showing, wow, it looks like CBG and its companions in cannabis are really bad for these types of cancer, and maybe they do things that the traditional treatments can't do, and maybe they're enhanced by the traditional treatments, and perhaps in the wrong situation at the wrong dose, it could make, or the right situation, the right dose, it could make things worse, right? Maybe it could actually enhance the survival of the cancer. There's just so many unknowns. THC and temozolomide had modest benefits and also sometimes had antagonistic effects when added to the combinations of CBD and CBG. But they didn't do that when added to the optimized combination. So what that means is the researchers tested all these different combinations of CBG and CBD. When they had the optimized, the best combination, and then they added THC or added temozolomide, it seemed to enhance the benefits. But in other situations where they weren't using the optimized combination, adding THC or temozolomide in some cases decreased the cancer killing ability. Again, there's just so many unknowns. We are so far from taking this data and knowing how it applies to our patients. Are we getting these concentrations in the brain, and what are the optimized concentrations? There's just so many unknowns here. But I think for now, the take-home message is that CBG could be providing additional anti-cancer effects in some people at the right dose. And I know that's a big stretch from knowing exactly how to practice clinically with this. CBG was shown to inhibit invasion, meaning the tumor invading the brain more and more powerfully than CBD. And then low concentration CBG was shown to be more effective than the highest concentration of temozolomide when it comes to inhibiting invasion of the brain. So, wow, lots of, and then another thing that is a little bit off topic here, but these researchers also published this in the study. They looked at these, remember, they had this huge variety of cancer cell lines from different patients that seemingly responded differently to the cannabinoids. And so what they did was test, do these cancer cell lines have CB1 and CB2 receptors? Yes, they all had both CB1 and CB2, but the expression was pretty different. Some had a lot, some had a little. And again, this suggests that we should expect large patient variability in their response to cannabinoids. Wow, lots there for CBG and cancer. Before we move on, any comments?
So I have a comment. One is great review of a very complex paper. This paper has a huge amount of information in it. So thank you for that. It really helps, Dustin. And then the other thing that I wanted to say is we know that glioblastoma multiforme has dismal outcome. And I certainly think, and we know GW is doing research with the CBD THC combination with temozolomide, it is time to start doing clinical trials with CBG and CBD. It's how long do we continue to lose people to this awful beast? So I think it's time with this information. It is complex. And I understand that we're going to have people who may not respond, but ultimately, this is deadly and very quickly deadly. So I do think it's time to start doing some clinical trials.
Thank you. Yeah, hard when you look at the efficacy of our best treatment right now, 2 months of more survival, and that means 5 days of radiation a week for 6 weeks, plus an oral chemotherapy agent, buying somebody an extra 2 months on average. That's not very promising. And we've seen animal studies, case reports, some human studies of CBD and THC actually killing the cancer. I've had patients, not many, 2 that I can recall, that have used really high doses of cancer and halted the growth of a glioblastoma for a prolonged period of time. So it doesn't work for everyone, I promise you that, but in some people it does seem to work in combination or not in combination with conventional treatment.
And starting earlier rather than starting later. That's a big difference as well.
I think the other thing that's important to note is that several studies have shown that THC and CBD can have protective effects when it comes to radiation, like protecting the healthy cells from damage, and also sensitizing the cancer cells to the damaging effects of the radiation. And then the synergy with temozolomide. So it's like agreeing with you, Bonni, yes, it makes perfect sense, especially for people that want something as an adjunct to conventional treatment. Even though there's a tiny bit of data that suggests doing it wrong might get you the opposite result you're looking for, I think there's much more data that's suggesting we're going to get more benefit if we add these in with the conventional therapy. Now, I think Rebecca Abraham has a question pertinent to this topic. So go ahead, Rebecca.
Thank you. I'm so excited. It's a real honor to ask a question in this crowd. So I am a registered nurse, and I actually am getting my doctoral practice doctorate in bridging the gaps between the cannabis industry and traditional healthcare. So this is all really fascinating to me. My business partner are 2 physicians that do primarily oncology hospital medicine at a large academic institution. And when we read through some of the studies, because we help a lot of folks with palliative with symptom control, because like Dr. Goldstein said, these patients have a really poor prognosis and there's really not a lot to lose trying at least cannabis for symptom control. And maybe there's some other positive benefits. And my medical partners joked that if this were a chemotherapy by a pharmaceutical company that increased the mortality like we saw in earlier CBD studies and CBG studies, they would have pushed this chemotherapy out. Do you also kind of feel like that's true? And is this actually hindered more because it's cannabis and Schedule 1 more than they're worried about how it works? And my second kind of tail question is, does CBG work better than CBD in some of these cases because of the bioavailability? Because they both cross the blood-brain barrier, but it seems like the bioavailability of CBG is significantly higher sometimes than CBD.
Yeah, great questions. Well, the first question I didn't understand perfectly. So the question is, are we kind of assuming that these are good compounds to use as an adjunctive treatment just because they're from cannabis, even though if they were from something else, we might not give them the same attention?
Well, sort of like that, but kind of the opposite. Like in clinical trials and pharmaceuticals, all they have to prove is kind of better than placebo and better than the drugs that came before, which isn't actually a very high bar. It's not kind of the high bar we think it is. And when we were looking at kind of the various studies of CBD and CBG, the physicians laughed because they said, if you saw any kind of chemotherapy that extended the lifespan of somebody 18 months, you would have seen this pushed out already. Like they kind of wondered, like, why not cannabis? Like where it's not as kind of damaging to other cells as chemotherapy.
Sure.
Plus there's actually like a therapeutic symptom relief happening at the same time.
Got it. Yeah. So I mean, I think cannabis carries some bias, against it. But I think what it really comes down to is just the money. If this can be monetized, it's going to be brought to market a lot quicker than if it can't be. And probably CBG is harder to monetize than some novel chemical that they've created in a lab that could have similar results. But that's an interesting comment that you shared. The question about bioavailability, I'm not sure that I've seen that CBG is more bioavailable per se than CBD. Correct me if I'm wrong, it might be, but it seems to be more potent, based on when people are using it, say for anxiety, they might need fewer milligrams of CBG than they do of CBD or something like that. But I'm curious, Bonni, if you have any comments.
I would defer to Ethan on that.
Bioavailability, Ethan, any ideas? Ethan might have stepped out. We just got his static image there.
Oh, okay.
No,
or maybe we don't know. Oh, hey.
Yeah, I don't think we really know that well yet on that. However, certainly it's seemingly effective in much lower milligram doses than CBD for most things. So I wouldn't worry too much. It seems to be getting in on helping people with a lot of different conditions.
Dustin, can I make just one comment about a clinical
Please.
case? So years ago, I treated a gentleman who had glioblastoma multiforme. He had the first tumor resected, started CBD oil, and then shortly after, I'd say 4 to 5 months, had a recurrence. At that time, he went and had surgery, and I saw him very shortly after the second surgery where we added in high dose THC. So I had him on pretty high doses of CBD and THC. He was a person who could tolerate the very high doses. He lived for another 5.5 years, completely symptom-free and tumor-free. He decided to go climb a mountain with his son in Europe and stopped his cannabis oil, and the tumor came back within about 5 weeks. So remember, these stem cells are there. Maybe we're just controlling them, keeping them latent and quiet, and when at any opportunity. So I know Ethan often includes this in his talks. The idea that cancer's completely gone is sometimes not true. And so those stem cells can be very difficult, and that's why this study was very exciting to me, because they addressed the stem cell, the glioblastoma stem cell question. But I recommend to patients who have cancer, who get to a point of NED, remember, you may have cells lurking. Don't stop your cannabis. I have other cases as well. Yeah.
Thank you. And even the stem cells, I mean, they were not completely eradicated. They were just, partially eradicated. I had a similar case, Bonni, of someone that was controlling GBM with mostly just THC. And he simply, he had about 1.5 years of stable disease. He felt like 10 years younger. He loved his high dose THC. It was quite high, about 2,000 milligrams per day. He cut his dose in half and the cancer came back. So, whenever I see somebody with an aggressive cancer have success with cannabis, I don't want to change anything. I know that's, people might not want to stay on this treatment for the rest of their lives, but that's, and once it came back, there was no stopping it. It just came back very aggressively. Yeah, and probably some of you are wondering, what, 2,000 milligrams of THC a day? How the heck is that possible? It was. He worked up to it gradually. He was taking it all by mouth, just dividing it into 3 times daily. He was never high or impaired. He had built tolerance to all of those effects of THC. He said his joints felt better. He had more energy. Literally, he kept saying that he felt 10 years younger on that dose of THC. It's just amazing. You never know. Okay, but I guess we're spreading out the webinar and taking questions throughout, but there's such good questions. I see that Susie has raised her hand. I'm sure it's relevant to this topic. So I'm gonna unmute you, Susie, and go ahead with your question.
Thank you so much. This is absolutely amazing. So I actually wanted to ask, and if you're gonna cover this later, please just say we'll cover it later. My question was around dementia and any studies on dementia, but also two other areas that I'm very intrigued by for CBG. One around tumors, whether they're cancerous or not, like fibroids, abnormal growths, thyroid nodules, if there's any information around that. If the studies haven't been done, that's fine. I'll look elsewhere. And like it could be fibroids or something like that. But also the other part of ALS, is there any information that's related to CBG versus CBD on ALS treatment? So dementia and ALS are the two bigger ones, and then anything in the women's health space. And if this is not the time for it, just push me aside.
That's all right. Well, we will talk about dementia later on, dementia and Parkinson's with CBG, and it's the only data that I'm aware of. I think there was a little bit in the study that Ethan published, but I don't think it was a big signal there. And then as far as cannabis and non-cancerous tumors, I am not aware of much information that suggests it would be useful for that. But you know, maybe historically some, but I haven't seen much like pituitary adenomas, fibroids. I haven't seen much in terms of cannabis helping with that clinically or in the literature.
Okay, thank you. Yeah, I've been doing CBD. I've been using CBD for a couple of years now, shrinking my fibroids with them, along with a couple of other things in my protocol. And that's why I was curious if CBG would work synergistically with that or not. But thank you.
Yeah. Now, and in terms of fibroids, right, there's a strong hormonal component there. It could be an inflammatory component there, a metabolic influence that affects the hormones. And, you know, these compounds affect all of these different things. So it could very well indirectly be helping shrink the fibroids. And I'm totally open to the idea that it's directly acting on the fibroids also. It's hard to know. But I think the idea is, how can we use cannabis to make a person as healthy as possible with an individualized treatment, and then see the healing system at work, you know, restoring things back into balance. Well, thank you. Great question. Okay, let's move on now to, where are we going next? Oh, we are going to anti-inflammatory effects. And I'm just going to cover this briefly. It wasn't a very in-depth study. Looked at purified CBG and or CBD in a guinea pig model of lung inflammation. They compared oral dosing and injection. And then for the oral dosing, they compared, for the oral dosing, they compared the MCT oil carrier versus this micellar solution, which was made from polyoxyl 35 castor oil, something called cremophor. And so the results of inflammation were measured in terms of the number of neutrophil cells that accumulated in the lung tissues of these guinea pigs. And you can see here, CBD did not really change the number of neutrophils at all, both when given by mouth in MCT oil, but when given, I'll say it didn't change anything when given by mouth in MCT oil, but when given at higher doses in this Krell solution, it did actually reduce the neutrophils. And so it seemed like to get CBD, at least at these doses, into the lungs in a significant quantity, it needed a special carrier. Just regular MCT oil, as far as these guinea pigs were concerned, wasn't enough. And then they did inject the MCT oil solution. That didn't do anything. But when they injected the Krell solution, again, CBD had a stronger effect based in the solution. Very interesting that giving it by mouth was stronger than giving it by injection at the same doses. You can see that 50 milligrams per kilogram by mouth had a pretty strong reduction in neutrophils. So this is curious. Most of the time we would expect an injection to be stronger than taking it by mouth, but that may not be the case when given in some of these carriers. So then turning and looking at CBG, no effect in MCT oil when given by mouth. strong effect or moderately strong effect when given in this Krell solution by mouth. Giving it in the Krell solution by injection did not work at all, not in a significant way. So again, CBG seemed to reduce lung inflammation in this model, but needed to be given in a special carrier by mouth. So what are micelles? This solution is a surfactant, basically, kind of like a soap that reduces surface tension and improves the dissolution of lipophilic fat-loving drugs in watery solutions like we find in the body typically by forming these little balls called micelles. They entrap the drugs within them. So you've got kind of the fat-soluble, fat-loving internal and the water-loving external, and micelles can be made in reverse order also depending on their purpose. But this is what the surfactant does. These little balls are much easier for the body to absorb and incorporate into the cells than just a regular oil carrier. And so and then the combination, there was no evidence of synergistic effects of combined CBG and CBD, so that it didn't seem like they had synergistic or additive anti-inflammatory properties when tested. And so the conclusion is that CBD and CBG have significant anti-inflammatory activity in the lung, but that formulation is critical to delivering an effective dose of these agents. And just an interesting finding that in guinea pigs, using this micellar delivery was really strong by mouth, even stronger than injection. Okay, any comments on lung inflammation or surfactants or any of that stuff?
Nope, not for me.
Okay, let's move on. The last study is a series of patients, standardized extracts enriched in CBD and CBG, real world experience of cases in Parkinson's and Lewy body dementia. This was not published in a peer-reviewed journal yet. It's been submitted. I found it on ResearchGate. It looked interesting, and so I thought I'd include it. We usually wait for peer review publication before covering papers in this format, but I wanted to get everything that was new and interesting about CBG, and I certainly found this new and interesting. So 14 patients with Parkinson's, 5 with Lewy body dementia. There were 4 formulations that the clinicians had to choose from. One, and again, these are not kind of broad spectrum. These are just isolates. So CBD, 2-to-1 ratio of CBD to CBG, 2-to-1 ratio of CBD to CBG with a little THC put in there, so it's still qualified as hemp, and then CBD with this little bit of THC. They were all 100 milligrams per milliliter, all in MCT oil. They started low and went slow and were administered with food. And so just want to show some of the improvements. So 9 out of 10 patients that had insomnia had marked improvements, not just a little bit, but really significant improvements. 5 out of 5 patients with anxiety improved. In musculoskeletal pain, 3 out of 5 had marked improvements. All of those 3 were on the formula with the CBG and the THC in it. Impulsive compulsive behavior improved in both of the patients that had that, and hallucinations improved in 6 out of 7 patients. When it comes to motor symptoms associated with Parkinson's disease, really nobody had improvement except one patient had some attenuation of his rigidity after he reached 4.5 milligrams of THC daily. Now, this is something we've talked about a lot before on the webinar, treating Parkinson's with cannabis. I know my experience is that I tend to see improvement in all of these other comorbid symptoms like sleep, pain, depression, anxiety, all the stuff except for the reason they came to me, which is they want help with their motor symptoms, meaning their tremor and their ability to move around and to walk and to not be so rigid. I do see some improvement in rigidity, but it's usually not profound. So it's just interesting that this study really kind of mimics what I've seen in the clinic, even though in the clinic I'm leaning much more heavily on THC and much less so on CBD and CBG. And I'll show you the doses that were used in just another slide. But this would be something I would expect once reaching a moderate level of THC, getting some improvement in rigidity. Out of all these, 20 or so patients, 19 patients, the only reported adverse effect was drowsiness. and that was promptly reversed with dose reduction. So no real downsides in this treatment. In terms of points from the discussion I found interesting, there's something called REM sleep behavior disorder that happens in Parkinson's with movement at night. And this can be due to a defect in the cholinergic system, so not enough acetylcholine or cholinergic signaling. And CBD has been shown to enhance this type of signaling in the basal forebrain, which is an area very relevant to Parkinson's. CBD was helping with insomnia in these cases, especially with the REM sleep behavior disorder. This study also suggests that lower doses than previously reported could be effective, perhaps due to entourage. So there was a human study looking at CBD for REM sleep disorder in Parkinson's patients, and they needed 75 to 300 milligrams, but this study needed a lot less. So I just selected a few of the cases. I didn't want to, belabor and take the time to go through everything here. But I'll just show you some examples. So, the first patient had pain, compulsion, insomnia, REM sleep behavior disorder, and anxiety. The effect was good. The overall effect was good. This is the one that had reduction of rigidity with 4.5 milligrams of THC. So what was he taking? His daily dose of CBD was 100 milligrams. His daily dose of CBG was 50 milligrams, and the daily dose of THC was 4.5 milligrams. Here's another case where they had limited benefit. It was mostly ineffective for the motor symptoms, low back pain, and the REM sleep behavior disorder. He discontinued treatment after 1 month. This patient number 2 was just doing the purified CBD. He was not getting CBG or THC. And, that's probably why. Too bad his clinician didn't choose a more complex formula for him. Here's another case of insomnia, REM sleep disorder, pain, mild hallucinations, had very good results, was able to stop using Ambien or Zolpidem. Fewer episodes of somnambulism, moving around at night, kind of sleepwalking. This patient was using, on average, 41 milligrams of CBD and 20 milligrams of CBG during the day. So these are pretty modest doses. That's the whole daily dose. So that's divided into 2. So 20 of CBD and 10 of CBG twice a day, getting good results with this. I think that's pretty impressive. Stopping Ambien, that's powerful. And so I'm not going to show these all. This is available on ResearchGate. You can download it and take a look. I just want to move on. They're cool cases, but I think you get the point. I'll just move on to a few of the Lewy body dementia cases. So here's someone that had severe hallucinations, wandering, REM sleep disorder, fast cognitive decline, and sundowning, had good results, mild mental confusion in doses above 45 milligrams of the 2-to-1 formula, stable on the actual dose. The actual dose was 30 milligrams of CBD and 15 of CBG. That's divided twice daily. So 15 and 7.5 gave good response to these symptoms. Again, that seems pretty potent. I'm impressed. And then, also really hard to believe was this patient who had insomnia with nocturnal agitation, marked Parkinsonism with gait balance problems, cognitive fluctuations, and pain due to arterial insufficiency. This patient was taking 5 total milligrams of CBD daily and had a good result with that, and clozapine was withdrawn. I shake my head, but sometimes cannabis really works at these very low doses. And sometimes we try the high doses without trying the low doses and we miss something. So I like to point that out, that, there could be something there with 5 milligrams of CBD. I would have never expected it, but cannabis is constantly giving me things that I don't expect. And that is the end of a very long slideshow. Thank you for sticking with us, everyone. Let's take a little stretch. I don't want to keep my guests around for too long, but we'll take some time to answer a few more questions and have a nice discussion. Have a drink, have a stretch, wiggle your body around. That was the long one. But now we all know a lot more about CBG. I am going to, we had some previously submitted questions, which I like to answer first, since that's what people submit them for that purpose. And so, yeah, I just wanted to dig in here. The first question was, any information on treating Wegener's disease, also known as granulomatous, with polyangiitis? I have never treated that condition, or I mean, it sounds slightly familiar to me, but I don't recall that. I believe it's a painful condition. Have you had any experience, Bonni, with that?
I haven't treated any patients with that, although I did take a look since I got those questions ahead of time. They're using immunosuppressants to treat these patients. So certainly cannabis may play a role and may help to modulate the immune system in these patients. Again, in terms of prevention, it's hard to know, but when there's vasculitis and pain, certainly cannabis should be considered.
Thank you. Another question was asking about CBDA and CBG for neuropathic pain in cancer patients. Can they be taken together? Well, I think we've talked a lot about how probably very good to take them together. You saw a lot of cases of Parkinson's and Lewy body dementia where they were taken together. There could be some people at certain doses where taking them together doesn't work well. What about dose recommendations? What am I seeing for CBDA and pain? I've been pretty impressed. I think people are often responding as little as 5 to 10 milligrams. And I've had very few people go up more than 20 or 30 milligrams of CBDA. CBG I have less experience with, but it seems like in that same range, right? Less than 30 milligrams. Would you agree, Bonni?
Yes, I've had 2-3 cases where people have gone higher. I had a gentleman, 90 years old, who's been my patient for a long time, takes a whole bunch of kind of low dose stuff to maintain wellness. And he's been doing really well. And lo and behold, he developed gout and went to about 5 different doctors. And all he got was opioid after opioid after opioid, which he was unwilling to take. And we started him on 50 milligrams a day CBDA and titrated up very quickly at 200 milligrams twice a day. So big dose, 400 milligrams a day. His gout was completely eliminated after getting to that dose after about 4 days. So I was very aggressive because he was miserable. And then with other patients with CBG, normally, again, it's like CBD, it has a wide range, a wide therapeutic range. It seems like some people respond to 2 milligrams. And then other people need 40, 50, 60 milligrams. I haven't gone higher than 100 milligrams with CBG on anybody just yet.
Okay. Yeah, great gout case. I mean, kind of similar dosing to indomethacin. And that one, rodent study that looked at COX inhibition with CBDA, I think it was comparable to indomethacin. And so I love the way you're thinking on that. Yeah. And what's the downside of using high doses of CBDA?
No side effects.
Yeah.
No side effects. And I always think of you, start low, go slow, but don't be afraid to keep going. So that was my motto with that guy, because he was really miserable. He actually contemplated suicide. He said, I'm not going to continue to live like this. And that was why he said, I'll do whatever you say. So we just ramped it up and we got great results. He was thrilled.
Wow. Awesome case. All right. We'll take one more previously submitted and then turn it over to a live question. Or maybe 2 more. This says, this is from Sarah Lee. Will CBG work better than CBD for either asthma or long-term systemic infections? Probably depends on the case. It seems like CBG has the strongest antimicrobial effect. So that might be something to try for long-term systemic infections, but it probably really depends on the type of infection. I doubt CBG is effective antimicrobially against everything. And as for asthma, I've seen people do well with CBD and THC and CBDA. I haven't seen CBG. Curious if you have any thoughts, Bonni.
I think you mentioned, so I was looking at bronchodilation. We have to know, it seems that the mechanism of action for bronchodilation is direct stimulation of CB1. And it looks like maybe CBG has a little stimulation. I don't know that it's enough. I know very low dose THC can cause bronchodilation. In terms of infection, I have to tell you, I don't know dosing for infections. I haven't really treated anybody other than patients who have who are colonized with MRSA who get like little breakouts. I've treated them with topical cannabis products. But in terms of infections, I'm always kind of scratching my head about what dose and how long. And Because remember, untreated infections can become a real big issue and you can land in the hospital. And so I'm usually a bit nervous about treating patients, not knowing without clinical trials. It's hard to know what dose of which cannabinoid for what infection. I don't know how you feel about that.
Yeah, no, I agree. It seems like, what I would add is it seems like CBD and CBDA can have benefits in asthma, not via bronchodilation, but probably via the anti-inflammatory effects. And that might not just be asthma, but as some of you that have been with the webinar previously, we looked at some animal model data, or maybe it was ex vivo model data of SARS. It was the ARDS, acute respiratory distress syndrome model, showing that I think CBD and or CBDA was effective at reducing inflammation and improving that type of lung inflammation. As far as chronic infections go, I mean, in my neck of the woods, we have a lot of tick-borne disease. I see people doing very well with cannabis in terms of symptomatic treatment and kind of balancing out their physiology so that they can respond better to these chronic infections. I'm not sure that it's having a direct antimicrobial effect in these cases. What I suspect is that it's just helping their immune system fight the infection. Some of the exceptions to that rule might be that I've seen people do, in certain cases, when they switch over to a high dose, kind of like a cancer type protocol, get better when they have not gotten better using low kind of symptomatic doses. And so maybe, what I'm suspecting is they're probably just getting a ton of essential oils and terpenes, which have antimicrobial effects, high doses of THC and THCA, probably are having some antimicrobial effects. The other thing worth mentioning is that there's just a tiny bit of data that THC might not be good when the infection is due to yeast. There's just a couple animal models that have shown worsening candida infections when THC was given. So we'll throw that out there too. All right, let's take a question from Shelly. I'm going to unmute you. Hello, Shelly.
Hi, how are you? It's an honor to be here. I have two questions. As far as CBG is concerned, are there any contraindications with CBG and those on antihypertensives?
THC can lower blood pressure, CBD can lower blood pressure, CBG can theoretically lower blood pressure. So I say if somebody's overtreated with antihypertensives, that would be the first place that I, would be concerned about is, adding cannabis in any form could lower blood pressure a little bit. It's not going to lower it a lot, but if somebody's already dangerously low, then they might need to be careful, about an additive effect.
And no concerns as far as, well, I shouldn't say no concerns, but depending on the type of antihypertensive, whether it's a beta blocker or an ACE inhibitor, is there any difference?
Well, I think beta blockers are more problematic because when somebody is getting low pressure, like too low for their physiology, usually they can raise their heart rate to compensate partially for that. But the beta blocker could prevent the heart rate from going up as well. So if it's truly just a vasodilator or ACE inhibitor, I think that would be less problematic. But if their blood pressure is low and their heart rate's low, it's going to be more symptomatic.
Okay, and my second question is, with CBG being shown to cross the blood-brain barrier, could it be potentially helping or inhibiting the uptake of medications, other medications, SSRIs, SNRIs, THC and CBD? Does it make it work better? Can it inhibit them?
Yeah, it's possible. There was a study. I don't know. I don't think many people know. Not much of the stuff has been studied at the blood-brain barrier, and the BBB of rodents could be different than humans, and that could be different than humans that are healthy versus those that have disease. But there was one interesting study we covered recently that looked at the absorption of CBDA in the intestine. And it turned out that low levels of THC or CBG significantly, like 16-fold, improved the absorption of CBDA. And that was due to the inhibition of this efflux pump. It's called the breast cancer resistance protein. The name doesn't really describe a lot of what it does, but basically, as the CBDA gets absorbed into the intestine, it gets kicked back, I mean, into the blood, it gets kicked back out into the intestine by this efflux pump. And the presence of small amounts of THC or CBG prevented it from getting kicked back out. So CBDA levels were much higher in that context. Could something like that be happening at the blood-brain barrier? Yeah, I think it could, but I don't think we know.
Thank you.
You're welcome. Okay, let me get back to the previously submitted. This is from Pam, who thanks us both, Bonni, for our contributions to this field. And I'm sure that thanks goes to Ethan as well. What are the uses for cannabis that have the most research? If you had to pick the top 5 or the top dozen, yeah, at least some promising data in humans, placebo-controlled. Wow. So, I mean, pain is up there. Pain is probably the best. Multiple sclerosis, all the Sativex trial, like whatever Sativex has been studied for, right?
Epilepsy.
Cancer, yeah, well, right, the Epidiolex trial. So epilepsy, pain, and multiple sclerosis.
There's a fair amount of research on nausea, vomiting, because that was one of the first indications.
Yep, chemotherapy-induced nausea and vomiting, especially.
Yep. There's not a huge amount of research on anything because of the restriction, but luckily we are seeing an uptick. You know, I just recently reviewed PTSD for a talk, and there's a fair amount of research out there now, just in the last 3 to 4 years.
Mm-hmm. Yeah, PTSD is growing. It's lagging behind. I mean, I think when we started practicing, we were seeing, I was seeing a lot of pain in a lot of PTSD patients. It seemed like here's all this evidence for pain, and there's like none on PTSD. And now we're starting to get there.
Right. Autism is also building huge interest, and a huge number of articles published just last year in 2020. Maybe COVID helped with that because people were home and not running around and doing more research.
Yep. Okay, Simone, I don't want to like step out of order. I see Lonnie with his hand raised. Is he next, or is there somebody that's queued up for the next live question?
There was one other person ahead of Lonnie, and then I have one other person after him.
Okay, cool. I'll let you call on that first person then.
All right. Lee was next. Let me see if she's still on. Yep.
Hi, thank you. Great topic. I love this central topic. And I just actually had a question of serotonin syndrome, because you presented, Dustin, one of the cases about it enhancing it. So do you worry about CBG with people that are already on SSRIs to promote, you know, can it cause serotonin syndrome in them? And then just another small question, are these genetically modified plants that don't have the synthase enzymes?
Okay, good question. I can answer the second question first. They're genetically modified through breeding, not through like GMO type practices, but the breeding is enhanced by gene analysis. And so basically what these breeders can do is get the cycle turnover between one generation and the next much faster, because they're able to select which are the individual plants that have the desirable genes and mutations, and then keep on inbreeding them with each other faster and faster. So it's just accelerated basically, but it's not unnatural genetic manipulation. It's through breeding. Now, as far as serotonin syndrome goes, you know, I don't know about serotonin syndrome. For those of you that aren't familiar with it, it's this like rare potential disease where people get hot and red, and it could be life-threatening and very dangerous when stacking multiple drugs that act on the serotonin system. I've been warned about it. You know, clinicians are supposed to look at it. I have no idea if it's more or less common than being struck by lightning, even when people are on multiple agents. If anybody wants to correct me if I'm wrong, but I don't know how concerning it is, honestly. I think I still sometimes say to people, like if they're adding CBD or CBDA to, you know, a serotonergic drug, you know, please, if you get really hot and red, don't keep taking this. And if it doesn't go away quickly, go to the hospital. But I don't know. What do you think about serotonin syndrome, Bonni?
I haven't seen it either. And maybe, you know, look, I work in the world of pediatrics, but I've taken care of plenty of adults who have been taking cannabis for years and years in combination with many drugs, and I just have not seen it.
Yeah, I think it's one of those kind of obscure things that we learn to warn people about. Lee, have you ever seen it in your whole career? Oh, you're muted again. Sorry. Let me unmute you. So you've spent lots of time in the ER too. Have you seen serotonin syndrome?
Yeah, I've seen it in the ER. I just, you know, I haven't, my cannabis practice is newer. And so I was just wondering, because you do get a lot of people for anxiety, and CBG is supposed to be good for it. And then you showed the study that said it could enhance the SSRIs, but I have seen it in the ER, and it's not pleasant. People are very uncomfortable, and you do worry about blood pressure and everything else.
Okay. All right, and I believe we've got, well, actually, I want to make sure we finish the spreadsheet before we move on, and there's just two more. So this one's for you, Bonni. Do you think FDA approved, it's an easy one. Could Epidiolex be more effective if it had a full spectrum instead of an isolate? And then also, can you explain why you say anti-inflammatory effects instead of calling them an anti-inflammatory? I think that second part of the question, they're basically the same thing, but what do you think about Epidiolex?
Well, so look, you know, I get a lot of grief for this. Everything needs to be on the table for these kids and for adults as well. When you're in that group of treatment-resistant epilepsy and your doctor's telling you there's nothing else, how are you to afford? Look, I have patients taking 2,000 milligrams a day of CBD to control their seizures. Their parents are going broke. Now their child is doing great and it looks like it's going to live a nice long life. How do you prepare for that financially? I do believe Epidiolex would probably have, this is just my opinion, would have better results if it was more whole plant. And yes, it had the right terpenes in it and a little more THC in it. However, what I have done with some patients who financially have not been able to afford the full dose of whole plant, they have been able to get a prescription for Epidiolex depending on their neurologist and their condition. And they take half of their dose as Epidiolex and the other half as whole plant. There's no reason you can't mix them. And we are seeing some very nice results with a lower financial burden on the family. So again, everything on the table. If we could get free medicine or insurance covered whole plant, that would be the way to go. But there is a study that came out in 2018. You've probably seen, maybe you've talked about it, Dustin, by Pamplona, about like an observational meta-analysis looking at whole plant and kind of purified CBD. And when you compare, just looking in the observational, it's 71% effect benefits with the whole plant versus something like, I don't know, 45 or 46%. But if you hold them both to a greater than 50% reduction of seizures, they're comparable. But certainly less side effects with whole plant. I'll just put that, lower dose and lower side effects, significant.
Yeah. Yeah, I think that's a good strategy. If people can at least get some of this broad spectrum, that's almost certainly better than none. I was just looking at the chat and I saw that Jehan is present. Jehan Marku, if you have any comments or anything you want to add to anything that we've talked about tonight, I always really value your opinion. Raise your hand and I'll unmute you. And thanks for attending. I'm so flattered that my colleagues and people I really respect join in, and it's often surprising. But let's go with the next live question, and that is Lonnie. So Lonnie, you should be able to unmute now.
Hello, and thank you for such an amazing webinar tonight, Dr. Sulak, Dr. Goldstein, and Dr. Russo. It's amazing to have all three of you here. I have a few questions. I have been working with patients using CBG Keef recently. The past month, I came across that. I've been adding it. I have been talking to Dustin, and I've asked some questions of Dr. Russo in the past. And I make these CBD products that I'm using in experiments with patients of mine that suffer from PTSD and neurodivergence. And I've had great success with the CBD alone, using it in a partially decarboxylated manner to keep the acidic cannabinoids present. Adding CBG is something that's the next step. I've been experimenting with it myself. I've given it to them separately. I have not combined it in one product yet. But the experiment so far, I've noticed my heart racing at some points. I've had to radically reduce the amount that I take. It's got that biphasic aspect to the anxiety. The reports I'm hearing, it really helps with that. I've also noticed it really suppresses my appetite. I mean, to the point where I put some clothes on to go to a conference last week, and all of a sudden it's, you know, I need a belt. You know, different things that I'm noticing, but I'm really wondering, and coming to the point of having Dr. Goldstein here, in terms of neurodivergence, looking at children with autism, I have children with seizure disorders as well, and anxiety. What are your thoughts, and do you have any guidance on how to use these products?
Sure. So I have seen some really spectacular results in children with autism. I've spoken about them here and there. I haven't published anything. I have patients taking very low doses between 2 and 20 milligrams a day, with about a third of patients who try it who are nonverbal or low speech have had incredible advancement of speech, to the point where the parents are saying, how is it possible that this little bottle and these little, 0.3 mLs is making my child speak? So I have a case also of a child who had birth trauma, had 3 strokes right around birth, has some CP, has a, not too bad seizure disorder, who we started on CBD to kind of help with. Parents were very nervous about THC. It was like a 25-to-1 ratio, who did quite well with CBD. We saw some improvement in behavior, improvement in focus, and so on. When we added CBG, it was like catapult. I mean, this kid just took off. So in the right brain, I do think, and I don't mean right brain, I mean the correct brain, you may see some really spectacular benefits. However, I agree with you, biphasic. I've had some patients, and I always warn families, if you're going to start a cannabinoid, you must understand that low dose may aggravate your child, but that does not mean it's not going to work. What it means is we're going to kind of escalate up to the higher doses. I have used high dose CBG. I think I have a teenager he's a like adult size, big teenager, who found anxiety, ADHD, got diagnosed with Tourette, but wasn't a terrible case of it. A little bit of OCD as well, who was taking 40 milligrams of CBG divided in 2 doses with very good results, but started to have some sleep issues, even though people report, and Ethan's paper reports some benefit with sleep. Some patients in my practice, about 25%, report CBG late in the day is too stimulating, so we just give it in the morning. So I hope that helps you. I've added it to patients with cancer who have really, stage 4, it doesn't look good. In addition to CBD and THC, I have added CBG when there is some reports in the literature as well. And for those patients, I've gone as high as 60 to 100 milligrams a day. They really don't have a lot of side effects from CBD. I think it, again, depends on the baseline chemistry. And again, the kids with autism, epilepsy do have some baseline chemistry that's going to be different from most people. It's interesting that you lost weight, because a lot of people report that it helps with appetite.
Ooh, I found that the acidic version does something very stimulating. The non-acidic version does something a little bit different. It actually enhances the other cannabinoids. I actually have one other question. I saw it in the chat, and I don't know if Dustin has seen that, but it's sort of related to this. Another patient that I have who has pandas, and he's also on the spectrum. Yeah. Very intelligent young man. Do you think this could be helpful for a case like that?
Yeah, absolutely. I mean, the bulk of my experience with pandas is with THC and controlling the more severe behaviors. And it seems to work well in some cases and not in others. But I use clonidine a lot in pandas. Some of these young people. So for those of you that don't know, this is a type of a neuroinflammation that can cause psychotic-like symptoms. And it may be related to an autoimmune process and or a chronic infection. But they can kind of like get triggered all of a sudden. And parents constantly describe it like it's like a different person, and they will show signs of hypersympathetic activity. They start shaking, their face gets white, their pupils get dilated, and then they can attack themselves or other people, and it can be extremely dangerous. And I found clonidine to be useful in some of these cases. So potentially CBG could do what clonidine's doing and maybe do more and do better.
Thank you. That is awesome. Thank you so much.
Yeah, and I'm curious to hear your comments about pandas. Well, and now I think we're typically calling it PANS. The AS stands for associated with strep, and now we know that it's much more than just strep that can cause this.
Are you asking me, Dustin?
Yeah, what do you think, Bonni, about pandas and cannabis in general, or CBG?
Right. So I've treated a handful of patients with pandas, and we've had success with high dose CBD, very high doses. So, you know, epilepsy doses in some patients. And then part of that comes from, you know, families not being willing to use THC. They get very nervous about it, and you know how that goes. But also I've had some patients, the only thing they did respond to was THC. And I've also had some really nice success with just a 1-to-1 ratio. CBD THC and a 1-to-1 ratio allows for THC to do its thing and also help mitigate maybe some of the unwanted side effects.
Awesome.
Yeah, it's great. Thank you. Okay, I'm just going to jump ahead and unmute Jehan. If you're willing to make any comments on CBG or anything that we talked about tonight, or just say hello. It's great to have you.
Thank you, Dustin, so much. It's been a great way to spend a Wednesday evening out here on the East Coast. I just wanted to actually go back to CBGA and just throw something out there to see if you and your fellow panelists might want to comment. I think CBGA is really interesting, partly because there isn't a lot of information out there, and it seems to be like a weak agonist at a lot of stuff, like to TRPA1, TRPM8 receptor, other receptors like that. TRPV2, MAG lipase, COX1, COX2. And so I was wondering if, maybe CBGA might be modulating signaling, because sometimes when you have two drugs that like the same target, they can either enhance one of the other's activity through some sort of competition, or they can competitively inhibit each other. But I guess I wanted to just throw out this idea. Maybe you can comment on CBGA as this factor that can maybe enhance the signaling of other cannabinoids, because it hits so many other targets, albeit weakly, but it hits a lot of targets very weakly. But anyway, I just wanted to share that. But I think this webinar discussion has been fantastic. Thank you.
Awesome. Yeah, thank you. Well, I kind of had similar thoughts, and that's why I included it in our CBG formula, right? We had such success with CBD, and the Healer, the straight CBD formula from Healer is actually 6-to-1 CBD to CBDA. And what we found is that a lot of people are coming back and saying, wow, when I switch over to this formula from other products, it seems to be so much more potent and work better at lower doses. And I'm attributing that to CBDA. And so, when it came to formulate CBG, I basically just copied that same pattern, wondering if you'd be right, if it could kind of potentiate some of these benefits. And also, even though I'm not aware of it being studied, it's possible that CBGA is much more bioavailable, has better absorption through the gut than CBD, which we see with both THCA and CBDA. So a little CBGA might go a long way, and it might be a nice complement to CBG. So that's what I'm suspecting, but I've got no evidence to prove that, and hopefully we'll figure that out soon. And what about you, Bonni? Anybody taking CBGA that you've seen?
No, I haven't had anybody taking CBGA dominant. It looks like some products that patients are using with CBG have a small amount of CBGA. But again, when you have something that's got multiple compounds, it's always hard to tease out what's doing what. So I can't really comment on CBGA by itself.
For sure. Well, we are so late here. Let's, I know that Sean we'll do some rapid fire lightning questions at the end. Sean, you're up, man. How are you? And what's your question or comment tonight?
Okay, my question is quickly for the use of CBG in plaque psoriasis. I currently am using a type 2 chemovar that's very high in beta caryophyllene. And I was just thinking, I'm having some pretty good, my patches aren't as bad, but would adding some sort of CBG formulation, I heard Dr. Russo speak to this once, would that really give me the bang that I really need to really tackle this? I'm currently using teas for the psoriatic arthritis part, which is getting along quite well. So that was my question.
Yeah, so I kind of, and in that diagram I showed that showed all the potential uses of CBG, one of those little arrows was pointing to psoriasis. I didn't include that as a main point in my slides, and I can definitely get you that chapter of that textbook if you want. It was based on some of those trip ion channels. I can't remember which ones right now. Jehan probably knows, but I can, if you write us, I can get you that chapter. But yeah, I think that it could be a nice complement to what you're already doing. I would certainly try CBG.
And can I just add in, maybe try topical CBG? I have a patient that had one of the most horrendous case of psoriasis, and taking CBG orally combined with topical made a big difference.
Awesome. Great to know. All right, Laura, I believe you are the last one, or hopefully the last one.
Dustin, Rachel's been waiting patiently since.
Oh, sorry, it's Rachel.
Yeah.
Rachel, where's Rachel? Go for it, Simone. And then Laura will get to you.
I think she might have left. All right. Laura.
Sorry, Rachel. Okay, well, go ahead, Laura, and if Rachel comes back, we'll take her question.
Hi, thank you so much for taking my question and for all the work that you all do in this space. You might want to unmute Jehan for this too, because I know he's going to want to in. I am a licensed clinical social worker. I'm an addiction therapist and the founder of the Calm, Cool, and Collected. I know, Dr. Sulak, in your presentation, you alluded to CBG having promise to manage opioid withdrawal. So I know you've done a lot of work and I've read a lot that you've had to say about the efficacy of CBD for withdrawal and for addiction cessation. I was wondering if you could elaborate on CBG's role in that and maybe even talk about it in comparison to the current MAT treatments like Suboxone or buprenorphine. Thanks.
Okay, sure. So for opioid withdrawal, first of all, I think THC is a very powerful agent. If you look at the symptoms of opioid withdrawal, you've got nausea and vomiting and diarrhea and this hypersympathetic activity. You've got insomnia, muscle spasms, and then cravings, anxiety. All of these things are driving people toward relapse, and this is the acute phase of withdrawal. And when I look at that list of symptoms, that pretty much matches up with THC strengths. And so I really go with that. Now, when I have people that are in acute withdrawal, sometimes THC isn't enough. And I also offer this cocktail, basically. And so I use clonidine. That's the alpha-2 agent, and that is for the agitation. So they're shaking, they're sweating, they're having the hypersympathetic symptoms. Clonidine works extremely well for that. I'll use a combination of promethazine and loperamide for the GI symptoms. So these are both, the antiemetic and the antidiarrheal, but they both have dopamine activity, which can also make the person settle down and get a little sleepy and just kind of satisfy that need for the dopamine fix. And then I use sometimes cyclobenzaprine if THC isn't controlling the muscle spasms enough. When it comes to CBD, I think that, that can in high doses help with the acute withdrawal symptoms, but I think it's going to be a much more expensive treatment than THC. I think at doses that a lot of people can afford, I wouldn't expect, very impressive results with CBD. Now, the research on CBD decreasing the cue-induced cravings, like some of that research that Yasmin Hurd did, where even 7 days after a single dose of CBD, people are still having, less cravings when they're exposed to a heroin cue. Yeah, that's just so powerful. And so I think we should really keep CBD in mind when it comes to the neuroplastic changes needed to get someone over their addiction and to make them less susceptible to relapse. I think CBD has a lot of promise. And so taking that all together, what role might CBG have? I think CBG could potentially help with the hypersympathetic symptoms, that agitation that happens with withdrawal, which is quite miserable from what I hear from people. Any comments, Jehan? Anything you'd like to add to that?
Sure. So I've done some clinical research, observational research with cannabis products, case reports, and retrospective analysis. And unfortunately, CBG wasn't one of the things we saw in the products people were using or were able to track. But I think I want to just stress, as editor-in-chief of a journal, we get a lot of like wild things that should never be published. And we also get some concerning things that we think we should publish right away, or trying to figure out the best way to deliver them. And however rare they are, I am aware of some adverse events associated with CBG-rich products. Now, it's not saying, CBG is a culprit, or it's a perpetrator, or is it the victim of a drug-drug interaction. That there's a lot of factors that go into that. But I definitely, I think Ethan Russo's article also speaks to this, that there are some adverse events with these substances, and especially with opioid use, and getting more into the weeds on clinical research in doing a proper opioid trial. There's this window that's very difficult when people are transitioning from, a pharmacological treatment to nothing, or from one pharmacological treatment to another when treating opioid abuse. And if they have an adverse event with a product, I think that can limit its success. So again, I've seen some unpublished, unsupported rumors, let's just call them, about adverse events associated with CBG-rich products that are used also in combination with nicotine products like a CBG Bonni. So I don't know if anyone else has experienced that. Again, people send me all sorts of stuff to read, but I didn't know if any of my colleagues on here might think of a rationale why someone might have an adverse event from a CBG-rich product, like losing consciousness, or getting really confused or dizzy. Anyway, I just wanted to share that. Again, I can't substantiate any of these case reports about adverse events, but again, I sift through a lot of this stuff. So any guidance here would be great.
Thank you. Oh, wow. We're really cooking here. Longest webinar ever, and it keeps getting better. I would just guess that, the antihypertensive effects could be the biggest culprit there, but who knows, right? We've got so much to learn about this.
And Dr. Goldstein, do you ever see anything in the population that you work with? I mean, kids are definitely a population that's affected by the opioid crisis. Is it something that you've seen or experienced? Not so much. Okay. Thanks.
No, I don't really see kids with, and I'll tell you that children with pain are undertreated because people are afraid to put them on opioids. So there may be teenagers abusing opioids, but it is very unusual for, except in dire cases where children are dying of cancer or so on, they don't get, I get kids that come in crying with 10 out of 10 pain, and nobody's addressing it because they're terrified to give them opioids.
Thank you. Thank you all.
Yep. Thank you, Laura. Okay. Well, thanks for the 223 that stuck with us for the 2+ hours. Incredible. Thank you so much, Bonni, for your generous donation of time and experience and expertise. And we've got a trade, so we'll schedule the next how I can get you back and repay you for all that you gave to our community tonight. For those of you listening that feel like you received something of value tonight, and if you feel compelled to make an exchange so that you're in a fair position for receiving this value, I encourage you to go to healercbd.com, buy some CBG from us, use the coupon code CBG for 20% discount. Come back next month and tell us about your experience. We just have so much to learn from each other. And if that doesn't interest you, you could go to healer.com and sign up for the training. Code webinar for $50 off. It's great training, community, great curriculum, all the webinars recorded, and we are getting ready to produce some new content for the training curriculum related to specific conditions. So get excited about that. And just thank you all. I hope you have a great month, and take this information and continue to do the good work you're doing.
Happy Thanksgiving, everybody.
Good night, everyone.